Thanks for everybody for coming tonight. I hope everybody's been able to stay healthy and safe through this trying last few months, and nobody was injured shoveling anything in their front walk tonight or today. I know I have to look forward to that when I get home later. I thought this would be a fun topic because it's hopefully getting to the end of winter and we're going to start thinking about getting back outside. And as that happens, we all start thinking about spring and summer sports. And this is one of those things where I think we all get asked a lot of questions, and as both providers and athletes and recreational golfers and maybe more serious golfers, what are the things that I can do to help prepare myself for the season? And then what are the things that are commonly injured so I can think about them so that maybe I can avoid some of those problems moving forward. Okay, so let's just kind of do a quick little synopsis here. I'm not going to spend a lot of time about joint and joint inflammation, but I think it's an important thing that we talk about before we move forward is to what are the things that limit us when we're doing sports. So we know that pain is a cycle, and we know that joint inflammation is one of these cycles. And so when we talk about treating these problems, when we talk about the cycle of inflammation, we think about the fact that pain often leads to stiffness because we don't want to move the joint, which then leads to more muscle tightness, which then makes the loss of motion. And so where we live, we happen to have 4 seasons. And so as we do that, we need to be thinking about trying to maintain muscle and joint mobility. And we need to be thinking about exercise in general so that we can prepare ourselves in avoiding some of the pain that we'll often see when we start into sports and we transition through the seasons. So I like to have a quick talk every time I have a conversation about athletics, athletic injuries, and talking to both the adult, the masters, the middle-aged, and the senior athletes, that there's 3 elements to good health and well-being. So certainly we can talk at a different point about eating and medicine and things like that, but I think tonight we should really just focus on body mechanics, and overall health. And so my mantra of good health is the thing that I speak to all of my patients about when we talk about this, is that good exercise plans means 3 things. I'll translate through it, and some of the slides may have some technical words, but I promise I'll translate as I'm going, is that the biggies are this, that when we think about the mantra of good health, there's resistance training, which some of us would think in terms of weightlifting. But I don't want people to think about necessarily going to the gym. I want us to think tonight about what are the things that I have in the house, what are the things that I can use to simplify, and what are those things that we can use to try and maintain ourselves without having to go to the gym at this point if we're not comfortable. So there's resistance training, there's endurance training, or what we would think of as cardiovascular training. And then the last is the balance and the flexibility. And so most of us think about resistance and endurance training as part of our health, but the balance and the flexibility is often the thing is lost. But it's also the thing that we see, especially as we start talking about golf injuries, that flexibility and rotation is really one of the key elements of good mechanics. And so much of golf and golf injury is around mechanics that I always want you to think about these 3 things. And so those are the 3 things that we're going to go through in different forms. Now, equipment is one of those things that's certainly fun to talk about, and I'm certainly not advocating for everybody to go out and buy a new set of clubs. But as we get ready for the season, it's probably worth doing the check on your equipment. So if you see that you've had an injury, if you see you've had some body changes, if you've seen that you've had some issues, then I want you to think about just looking at your equipment as you prepare for the season. Gloves, that's a simple fix as we move forward. Checking the grips on your clubs, thinking, do these need to be regripped in preparation for the season? Well padded, comfortable golf shoes that you're going to feel comfortable walking, hopefully walking the course. And then depending on your foot stance, if you've had prior knee injuries or foot injuries, thinking about insoles or a good supportive shoe, insole that'll go along with that. Generally speaking, when we talk about golf injuries, we talk about it in terms of 2 different types. One type is just the repetitive use injury, or sometimes we think of it as an overuse. And the other is the traumatic injuries, where we have a defining episode where something occurs which leads to an injury. But the reasons for those injuries can be multifocal. And so we'll talk about some of these things. And I am by no means an expert golfer, as my friends and father, who I think may be listening tonight, would tell you. I am far from single digits. I'm hoping only someday to be in the teens probably at this point. But overuse is really the biggie. Mishits, hitting the ground before or after, swing mechanics, those are the kinds of things that we can certainly address easily. And I think it's worth spending time early on in the season as you start to warm yourself back up, thinking about just working on timing and rotation and avoiding that issue of overswinging. Whenever possible, warm-up is a key element, and we'll talk about that later in the talk. And then thinking in terms of a coil. And so in past, we used to talk about bending and rotation through the hips and the back as the means of modern versus older golf swing styles. But I really want people to think in terms of kind of a coiling action is that spring, not just load and compression, but as we kind of twist and it uncoils, that's where we generate our power as we go through, as we move through the swing and into follow through. When we think about injuries though, this is generally the order. I took knee out of this, but we can add that in probably between shoulder and foot. Back, and I'm going to add torso maybe to that, and kind of that area between kind of our middle area here is probably the area where we think about the most. Elbow and forearm will often go both with the chronic overuse as well as traumatic, either from a mishit or hitting fat behind the ball. And then shoulder and arm, also we see that, and we think in terms of breaking up just by convention, as shoulder generally goes from the arm to the elbow, and then for the elbow down to the wrist is considered the forearm, as we think about those things going through it. And then there's knee and there's foot and ankle, but just in terms of general epidemiology, that's the order that we see. But there really aren't any great large scale epidemiologic studies on golf, because it tends to fall into certain categories when we're looking at those things. So let's talk about the medical word, or the mechanics word, which is called kinematics. Kinematics is just how the body moves. And there's 5 phases to a golf swing. And I think it's always important to think about those 5 phases as we go through these things, because as you break it down and you think about how those things can occur, that's really where you start to see trying to focus on the strengthening and the stretching, helping to avoid some of these injuries. So we talk about it in terms of the takeaway, which is also called the backswing, the downswing, which is where you start the initiation of forward motion as the club starts to come forward, acceleration as you start to build more or less past the equator and then through contact. Contact is a point at which we reference, and then an early and a late follow through. But let's look at the golf, let's look at the anatomy on this. So again, I'm going to use some medical words as we go. I'll try and translate as we go. There's certainly no test, but I want you to think about the complexity of the swing. And so rotation in the golf swing is the key to driving power. But how we bring the club back, how we stop, and how we initiate, where the hips may roll and where we start to see our arms, is where you start to see those overuse injuries. And it's where you'll start to see either the push or the pull, leading to either a slice or a draw. But understanding that when we talk about this, it's definitely the old hip bones connected to the knee bone kind of thing, because you can't really separate the spine from the torso, from the hips, from the knee. Even though we try and break it down in terms of the injury patterns, those are the things that we look at here. So just thinking in terms of the muscles that attach to the chest and the back, those muscles that are going to attach primarily in the area in the back and in the low back, the muscles that we talk about on the side in terms of the rotation, and then those transition muscles between the back, the teres minor and the teres major, between the shoulder and the shoulder blade as we work through that. So here's the five phases. And in orthopedics or in sports medicine in general, we like to break things down into convention in terms of how we do this. It helps us as providers think about the mechanics in terms of activation of muscles. And I'll show you in a second, the number of slides that, the number of muscles that we're going to talk about as we look at those things. And we really think about the complexity of the swing and why it's so easy for so many things to go wrong, and why you may have one good day today and then the next day it all falls apart, is when you understand that there's more to the mechanics and how our back relates to our pelvis, relates to our hip, relates to our knee. Those are the things that kind of go back and forth. So again, the 5 phases is the takeaway. We talk about it in terms of that early forward swing until, there we go. Where we start to see those things moving as we go from that level or the equator, it moves from forward swing into acceleration. At contact, that's our point at which things change, into then the early follow through and then the late follow through. So think about those 5 elements as you think about each of these injuries, and we think about how we can try and keep ourselves strong and injury prevention going through these. So one of the things that's really started to change over the years is as we've gone from what some would say a modern swing versus a traditional swing. And there's certainly a lot of, I would say opinion if you read about these different things as to whether or not really matters. Should we think about it in terms of swing mechanics and age related, someone who's had maybe replacement versus back surgery? It's not so clear when we look at this as trying to modify different swings and trying to bring elements from each of these things into our own body styles and into our own strengths to see what works for us. So it used to be that we would talk about this reduced separation between kind of the hip and the shoulder across the bodies. Now what we're starting to see is, again, we're not thinking in terms of a bend twist, but we're really trying to think of that coiling action, generating velocity. In the thrower and in the overhead athlete, we talk about generating coiling as they get their arm back and kind of late wind up, so that you're using your whole body and the last thing that comes forward is your arm. This is where the mechanics of golf are very similar, is that you start to see some of your pelvis and some of your hip action moving forward as you start the initiation. The difference here is that in a thrower, where they're really single arm, you have this balance between the lead arm and the trail arm in terms of the pull and the push. And those are the things that you start to see where some of the injuries can start to occur. And so I'm going to do most of the talk generally tonight in terms of a right-handed golfer, so that we think in terms of a lead leg, lead arm, trail leg, trail arm. So what you'll see here, and I know this didn't translate quite as well as I had hoped, is that when you look at the player in the white hat versus the blue hat, you see how that knee drops and you see how the club is coming around. What we really want to think about is not the bend, and looking at their heel position is the other thing, is that in the traditional swing, people talked about that heel coming off as they bent their knee down. But that was more of that bend twist mechanics, whereas now where you look at the person in the blue, you're starting to think in terms of that twisting or the rotation mechanics, trying to coil through ourselves and then unleashing that rotation to bring the club face around and try and generate the velocity there. So let's just talk about 2 things. Let's talk about flexibility and let's talk about strength tonight. So when we talk about flexibility for golf, I like to really break things down, at least for myself, in terms of those body parts which we've identified. But it's not so simple as just saying shoulder versus torso, because there's the connectivity between the shoulder joint and the torso and the low back. And the torso and those connections between the shoulder blade, which is called the scapula, and the muscles that connect to the spine are really where we generate our early power up at the back part of backswing and coming down into the early part of the swing mechanics. So, straight leg hangs, which I'll show pictures of these as we go through, torso twistings against the wall to try and improve thoracic rotation, shoulder stretching against the wall, I think is very helpful. Floor stretching is always very, very good. Calf stretches against the wall, which is what we've probably all done for years if you were running or walking or anything along those lines. And then trying to think about hip flexion and, hip flexors and the hip stretches to really try and help ourselves get through, especially as we come through follow through, which is where you can start to see if you don't have good pelvis rotation and you don't have good hip flexibility, you start to create hyperextension in the spine. And that's where you start to see increasing pain and increased limitations through that. In terms of the strengthening, we break these down into these three things. So there's shoulder and scapular stabilizers. So those are we'll say the rotator cuff exercises, which we'll talk about, and then the muscles which support the shoulder blades. Then there's the legs and the hip as a separation. And then those middle things are those core exercises, which really don't just include our abdominal muscles in the middle, but those are also going to start to cross over and include some of those butt muscles and those gluteal muscles, and as well as trying to transition into the area between the core and those trunk rotations as they then connect back to the shoulder blade muscles. So let's kind of start to break those things down. I want you to think in terms of simplicity. We're trying to create a program where there is not a lot of equipment needed. And these are the things that we can all obtain either from our physician's office, from your sports medicine provider, from a physical therapist, or online. None of these things should cost very much. And these are the kinds of things that we can get creative to use, whether we're using bands or cords. I'm a huge fan of a foam roller, but none of the things that I'm talking about, and I'm only showing three things here, none of those things should really cost more than about $20. So again, great if you're a gym rat and you love going there, terrific. But if you're uncomfortable using the space right now, but you still want to maintain your flexibility and your mobility and your strength, I think that these three basic elements should allow us to do that with a good off-season program. The shoulder exercises, just as the basics. Again, using the doorknob, using a wall, something to tie it to, using exercises to try and strengthen both with the external rotations and those internal rotations to work both the front and the back of the rotator cuff. But thinking in terms of rowing exercises, when we think about those both as a low row and a high row. So there's the things where we're going to start low, and there's the things where we're going to be trying to pull up higher, not just focusing on the neck, but really thinking about pinching those shoulder blades together, trying to work on those middle muscles called the scapular stabilizers are really the thing where we're going to see a big difference. And we'll go through and talk about those muscles again. Basic exercises in terms of the gluteal muscles, the butt muscles, and those legs. This does not need to be crazy. These are very simple things. If you can do a double leg bridge, like we'll see in the upper left-hand corner, versus a single leg bridge, and then trying to just start using some very subtle side-to-side stretching, partial squats. I'm not trying to get somebody low. I know that some people are going to have reduced hip mobility. I understand that people are going to have some knee pain. Just the concept that you want to start working both the butt muscles and the core as you stabilize in those bridges, but also things that we're going to be seeing as we move from side to side to try and help contain and control the side hip mobility that we're going to need as we start initiating motion as we go through the backswing and into the forward mechanics. Trunk rotation and core stability, using these kinds of things, using your golf club as a means to stretch, using those same bands tied to the post, using a club to work on rotation. I know people are pretty excited about using the orange whip. I'm certainly not an advocate. I'm not a paid product person here. But the things that you're going to see online, some are great, some work for some, but the concept that we're trying to work just on hip mobility, hip strength, core mobility, and rotation are the things that I want you to look at when you're looking at these things. Hip stretches in general, laying down on the ground, trying to bring your leg across, working on that rotation, keeping your arms flat. If you have great mobility, you can certainly do it like the man in the bottom left with the red t-shirt. If you're working on your rotation and you're new to this, just laying on your back, trying to do pulling both legs up to the chest, things where you're working across the body to start working on rotation. Those are the things that you're going to start to see start to work on mid-season and even as a routine during the season to try and maintain that flexibility and rotation. But again, everything we think about is that analogy of the coil. So when we're doing this, I want everybody to think about how can I generate power in rotation and how can I then generate the power as I come down to unleash the energy of that coil. As we work through follow through, those are the things where we start to see the exercises that we were talking about that start to help. So those pelvic stabilizers that we can use to try and help keep the pelvis neutral through here, those rotation exercises against the wall to try and keep the rotation muscles here in these periscapular, the shoulder blade muscles, and then using certain maybe clamshell exercises where we're just opening and closing at the hips to try and maintain the mobility both in those external obliques as well as our side butt muscles, not just our gluteus maximus, but the ones that we don't all think about quite as much, which for golf are probably more important, which are the muscles called the gluteus medius and the gluteus minimus. I had said I was going to just kind of show quickly the complexity of this, and certainly there's not going to be any test, but when we teach residents and when we talk to sports providers, these are the things that we start to think about in terms of majority of activation, which muscles of dominant versus non-dominant side become important. And you start to see it's not that simple. So during any phase, if you look at it in terms of our 5 phases, you can see at any point, just in the shoulder blade muscles alone and those shoulder muscles, you start to see how many of them are under activation. And it's always this balance and counterbalance between your exercises. And so I like to talk to my golfers when I'm talking about strength training in terms of always trying to work a push exercise with a pull exercise, a curl with an extension, a strengthening in the glute muscles with a hip flexor, things where we're working our thigh muscles or our quadriceps with the back of our thighs with the hamstrings. So a push with a pull and an action and a counteraction are the things which have more stabilizing effect to any joint, which is why we always try and do those kinds of exercises and balance them together. Now, there's lots of things that can be related to swing. And so these swing modifiers, some of these things we can control and some of the things we can't. So trying to make someone who is maybe a septuagenarian or somebody in their 70s who already has arthritis, who may or may not already have a replacement, who may have some stenosis in their back, I'm not going to be able to teach them the same kind of mechanics that, you know, maybe a Tiger Woods used to see when he was in his 20s, and nor should we need to. So trying to understand that there's some degree of natural loss of motion that we may see through our trunk and spine, try and understand that how we can balance those things out. We can't change our gender. We cannot change our age. Arthritis, maybe we could change by talking about joint replacement, but I'm not going to talk much about that tonight, but maybe a touch on it at the end. But what we can do is try and maintain that range of motion and that strength no matter our age. Those are the things that we can do which really help to prevent injury moving forward. So as we do that, let's kind of talk about some of the injury prevention things. So I think this is one of those things that as young players, many people tend to either skip or they kind of do it for fun and they just go out to the range and they're taking out their woods and their irons and they're hitting hard and fast and then they're heading over to the tee box. I want you to think about this as a process. And so you would see traditionally that people would go out to the range, they would take out their short irons and then maybe their woods, and then they'd hopefully get a couple of putts in before they went over. I want you to think about this the opposite. Let's assume that you have the time and you can take a good 30 minutes to warm up before you go to play. Conceptually, you're going to be better off starting working from putting, where it's small action, limited motions, focus on balance, timing, moving to the chipping area where we're just trying to chip towards one site. Again, we're working from short to long as we go. As you go from the chipping range, then hopefully walking over to the regular range, trying to just loosen up, and then thinking about doing both a full swing stretch where you're maybe using the weighted clubs or a few clubs at a time. Then we move on to the wedges, then the irons, and then finally the driver. The idea is here that we're going from short to long, And by the time you finish, you should feel like you're nice and warmed up, you have full body mechanic rotation, and you're ready to walk right onto the first tee and you're ready to go. So I realize for many people this is different, but I want you to get into a habit of when you start to play that you're working towards doing it the same every single time so that you see what works for you. Again, when we were talking about the coiling and the turning, these are the things that there's certain body mechanic things that we can't change. The idea is that when we used to bring that backswing through, we were trying to bring it all the way back, that's the club back to parallel again. Now what we're seeing is that it's really more acceptable to bring up to the 1 o'clock position rather than all the way across. And those are the things about trying not to overswing, but we want to coil our bodies to the extent that we can, not just try and coil at the top or the bottom, because that's where you get those imbalances, and that's where you start to see the push versus the pulls as you start to get into the swing. So let's start breaking this down into the body parts here, and let's go through each one. Let's talk about what the rotator cuff. And like I said, there's certainly no test, but I want people to be a little familiar with some of the words, and so that we can understand what each of these things does, so we understand why they matter. So the rotator cuff is really just 4 muscles, that's all it is. But those 4 muscles then act like a sleeve and they attach onto the arm bone, which is what we see here. So you have the front muscle, which is coming over the top. Hopefully I don't advance my slide. Here, which is the front, called the subscapularis. And the subscapularis' job is to internally rotate the arm. Then we have the biceps, which is not a rotator cuff, but it sits right underneath the front or the top rotator cuff, called the supraspinatus, which is an elevator of the arm. Then we have the back corner, which is here, which is the infraspinatus, which is an external rotator. And then the last is the teres minor, which is this one which controls rotation as we come up to the top. So sometimes we call it the sits muscles, the subscap, the infraspinatus, teres minor, supraspinatus. But as we go from front to back, those are the 4 muscles. And so it's more about internal and external rotation and a little bit of elevation. But what I like to tell folks is, when they're trying to do rotator cuff exercises, the rotator cuff are not your beach muscles. These are the fine tuning muscles. These are the things that control our arm in space. It's not the things that we can flex when we go to the beach. So exercise programs for the rotator cuff involve higher repetition exercises, lower weight, resisted bands, because those are the things that are going to help prevent those mechanics. But they also bring in an element of endurance, which is one of the things that we're trying to see. Now, if you think in terms of looking at the back, and again, there's no test, but I just want everybody to think in terms of the color coding of this, the give and take of your trail arm and your lead arm. So as you come through your backswing here, and you have your trail arm, or at that point, and your lead arm on the front, what they're doing is they're balancing the shoulder blade in space. So you're going to have what's called protraction and retraction of the scapula. So what all that means is just how the shoulder blade sits on the chest wall, is that one is going to get pulled in and one is going to get pulled out as we go. And that give and take is exactly what we start to see as we transition from the takeaway backswing into the downswing and acceleration. And so you see, initially you're kind of bringing your scapula in and locking it into position as the other one comes across. So when things go away from the body, it's called abduction or abduction. And when things come across the body, that's called adduction or adduction. But when we talk about the shoulder injuries, the rotator cuff, I'm just going to, for simplicity, call RTC as rotator cuff, is the rotator cuff and the bursitis. The AC joint, I don't really want to spend any time on, except to say that that's what we start to see in people with really big swings, where they start to get some issues up on the top, where the collarbone meets the shoulder blade. Labrum is an interesting thing. As we talk about our middle-aged and our senior level golfers, labrum and instability really is not a big thing, because primarily we're not having issues with too loose of joints or instability where the shoulder's slipping out. We're generally seeing more an issue of tightness or a little bit of an imbalance between the back and the front, and maybe even a little bit of a glenohumeral arthritis. And glenohumeral just means shoulder. We talked about that transition as we go from our swings from front to back, in terms of that across the body being adduction, away from the body being abduction or abduction. But where we see our shoulder injuries occur are really at the very late and the very follow-through points, as we think about those takeaway and follow through mechanics on the shoulder. Generally speaking, thankfully, most golf injuries are not surgical. Most of them can be addressed when we start to see these overuse things as a function of physical therapy, anti-inflammatories, a good home stretching program as part of your maintenance. And then often we'll start to see some of these things during mid-season athletes coming in where we talk about, cortisone shots or biologic injections like something called PRP. Some of the newer techniques, or maybe we'll call it less traditional things, prolotherapy, ozone, or dry needling, which you're going to start to hear maybe more about from the physical therapy community and a little bit less from the physician provider side. Surgery is always a last resort. I tell my golfers, I'll see you in September with the plans to fix you in October so that we have the winter to rehab and you get you ready for the spring. Most of these things, if you're having a recurrent problem which needs surgery, most of them we should be able to nurse you through the season, and we do it when it's convenient. Trying not to overswing is really one of the keys. Again, I keep saying it, but understanding our own body mechanics, it's okay to shorten that backswing. The days of having to get that club all the way back and over to parallel to the ground or past are gone. Even when you start to see, professional golfers looking at the amount of backswing that you see as these guys start to get into their 40s, they're really starting to shorten that, and they're starting to use their own strengthening to work through their rotation and their strength through the midsection to try and generate their velocity and their club speed. Generally, look, the shoulder, it's not a particularly strenuous sport on the shoulder. It's more about the repetitiveness of it than it is about the violence of the mechanisms, unlike somebody, say, trying to throw a 100-mile-an-hour fastball. But understanding that balance between those shoulder blade muscles and those rotator cuff internal and external rotator muscles are the things that are going to help move us through understanding about that same balance of a push with a pull, a rotation right with a pull with the left, a thigh or a quad exercise, especially in the off season, with a hamstring. I wrote down in parentheses, both in the form of CKC. Again, there's no test on this, but we like to think in terms of strengthening joints. The medical word's called a closed kinetic chain strengthening. Closed kinetic chain just means in the lower body, we talk about the foot being fixed against an object. It can be a pedal, it can be a leg press machine, it can be a floor. But the idea is when you're doing those things, you're getting what's called co-contraction of both your quad, your hamstring, and a little bit of your butt to really engage and protect both the hip joint and the knee joint as a means of strengthening. Trunk is the next thing. This is really where all the energy is. This is where the excitement is. And this is where a lot of energy is getting spent these days in terms of hip flexibility and hip rotation. But again, we talked about the idea of that coiling and unleashing of the coil, which really generates between the shoulder and the thighs. And that's where you start to unleash the rotation. And that's where you really generate the velocity and the club speed to start working that towards it. Elbows, for the most part, it's easy, but it's hard. We talk about these two kinds of things as both a golfer's elbow and a tennis elbow. Ironically, I feel like I see as much tennis elbow in my golfers as I do golfer's elbow in my tennis players. The idea is that for the most part, these tend to be overused things. But what we see, and the reason it's so common in the middle-aged and senior athlete, is that the blood supply to those tendons, as we look at them on the inside and outside part of the elbow, the blood supply to those tendons as it comes down onto the bone isn't terrific. And so if the blood supply comes from top down, those deep layer tendons, as they attach onto the bone here, they just don't get the blood penetration here. And so that's why it's very often that we'll see these kind of tendonitis problems, or the medical words, you'll often see the word tendinosis. Tendinosis is just a fancy way of saying normal aging, but those deeper layer things. And so when you start to see your providers and you get ultrasounds or MRIs and you see partial thickness tear or tendinosis, many times that's associated with a normal aging process. And so I don't want people to get too fixated on testing when they talk about those things. And so the reason that we see that is, especially with the golfer's elbow, or what's called medial epicondylitis, where you see that is with the trail arm. And the reason is that, again, if we have our lead arm with a pull and we have our top arm, which is our trail arm with a push, as you do that, you're activating the inner part of your elbow. The opposite would be that in the golfer's elbow, sorry, in the tennis elbow, on that lead arm, you're seeing the outer part of the forearm muscles as you bring this down. And so that combination of the pull against the push is where you start to see the rotation in the forearm, is what causes some of those changes that you'll see it. So again, that common error that you see is trying to push the club down with that trail arm. And that's the thing where you start to see where you'll hit fat, you'll hit behind the ball. Where it's really an issue is that, in off-season training where we're hitting off the mats, you really can get into trouble because you're hitting a very hard surface every time you do it. And that vibration and that hitting a little bit fat, you'll start to see a little bit of pain coming around from that inside part. Generally speaking, whether you're talking about golfer's elbow or tennis elbow, the treatments are very similar. They almost become interchangeable. Where it's really important is maybe for me as a surgeon is when I need to start thinking about what am I either injecting, what am I rehabbing, or God forbid, what am I operating on, trying to understand some of the tendon mechanics so that I know how to fix those. But again, if I see 100 people with a tennis elbow or a golfer's elbow, I'm probably going to only ever come to operate on about 5% of those. Equipment changes, weighting, working from a steel to maybe a graphite shaft, or even a wider grip to take some of the stress off of the forearm grip, are some of the simple things that you can look at. Again, when you talk about your own swing mechanics in your equipment, and really do your own assessment year to year to see if there's been any changes either in your body or your body mechanics, which maybe would affect that decision making. Talked about this, primarily this is going to be an overuse injury. We've talked about the trauma from hitting fat or hitting behind the ball. I know I am definitely guilty of that. But it's those sudden decelerations of hitting the mat where you start to see that trail arm start to see some inactivity where it doesn't allow the forearm to rotate. And so as we go from pronation into supination, as we roll the forearms through, that's where you can start to get into problems with that. Especially around the elbow and the forearm. The tennis elbow, it's, I'm writing it down just for completeness. Don't really get hung up on the fact that it's the extensor carpi radialis brevis and the extensor carpi radialis longus. It's just the name of the muscles. But almost uniformly, it's those muscles, the ECRB and the ECRL, are the ones that we see as a problem. And so that's why we spend so much time trying to focus on strengthening those there. So when we talk about the elbow prevention exercises, this is a lot of lightweight, higher repetition, low resistance, low weight exercises. So trying to work the extension with the wrist curl to really work both sides of the forearm, trying to work the stretches both back and down to work both the extensor part and the flexing part of the forearm are the things that we like to see. Using some of those kind of squish balls. You don't need to do the old heavy military type or the metal cage things that we used to grip when we were in high school, but just trying to work on your grip strength to try and make sure that you're maintaining both the forearm strength in there. Biceps curls, we talk about doing 10 reps in 3 sets. Hammer curls, which are just kind of a neutral stretch. And then tricep strengthening, just again, in terms of the stretching. But I think the biggies are trying to think of really very, very low weight extension and flexing exercises at the forearm, and trying to really work on both your grip strength and the flexibility, both with the elbow straight and with the elbow bent. Wrist stuff, this tends to be a little bit more traumatic. I don't really think that too many people are talking to their healthcare providers about these. Just in terms of at that point of contact, where we start to see our forearm, the forearm in our hand as it meets, it starts to what's called ulnar deviate, which is it starts to go that way a little bit, especially on our lead arm. Those are the areas where we start to see a little bit of a tendonitis, generally down low on the pinky side of the hand, where those muscles are start to attach, or the contact point between the forearm bone and the wrist, and that's where we start to see some of those kinds of things. But again, rare, this is very, very low rate things. just thinking in terms of like, if I'm hitting fat consistently, those sudden decelerations are the things that will start to lead to a lead arm, ulnar or pinky side of the hand problem. Yeah. So we talked about using kind of larger headed iron, softer grips, looking at lighter shafts so that we can work on not feeling like we're having to muscle through with our forearm. It allows you to grip the club a little bit easier when you start to use these lighter clubs. It's also why we kind of talk about these senior and non-senior shafts, because the amount of rotation and acceleration you see is going to be less as many of us age. And so we're trying to use the mechanics of the graphite to allow it to catch up, which is why you don't see those kinds of clubs in the younger, stronger athletes, because it'll get too much and they'll tend to push the ball because of the way they kind of come through as they roll through, as they move at the point of contact with the ball. Now, low back is most common. Often this will be the insidious, which is kind of, you know, not expecting it, versus the traumatic. We've all had that day where we just threw our back out. But again, you'll see these more on that trail side during follow through. So we're always thinking in terms of lead and trail at the point of contact and rotation and follow through, which is where you start to see those things. Herniated discs can happen. Stress fractures, I think, are really quite rare. Arthritis is just a side effect of aging in our population. And so understanding that there's going to be a certain amount of follow through that we need to avoid with the rotation, because our spine, as we have a natural curvature to it called lordosis, you know, as we start to get a little bit of arthritis, you lose that natural curvature and it becomes a little bit straighter. And as a function of that, you just lose the extension on follow through. The key to that is understanding that you're trying to keep your backswing and your follow through about level in terms of the rotation to avoid the push or the pull as you're trying to avoid a hook or a slice on the ball. You know, muscle strain is most common. Thankfully, those things will resolve in time. Herniated discs, I think we all will see those a little bit. We know people who this has probably occurred to, but it's the stress fractures and the compression fractures. We'll see those more commonly in the younger athletes who really still have a lot of hyperextension and rotation than we do in the older or the senior level athlete. Prevention and stabilization is the key to success. Now is when we lay the groundwork for this prevention, doing those bridge exercises, doing core exercises, doing plank exercises, whether they're on your hands, your elbows, your knees, I don't really care. But the idea is that we really want to focus on those protective rotation muscles to prevent injury as we go into the hopefully longer seasons. We talked about increasing thoracic rotation, trying to stretch against the wall as a means both for increase in acceleration, but trying to do that as a means of acceleration and both injury prevention. And then we talked about kind of our pre-round routine, trying to understand how we strengthen in rotation, how we work from kind of smaller arcs of motion into bigger arcs of motion are the things that we like to see to try and work forward. Swing mechanics, I think we kind of touched on this a little bit, but you know, understanding the relationship between the shoulder and the hip helps us to understand how much backswing is appropriate. And I'm certainly not advocating that you should, you know, increase or decrease. I think, you know, using your golf pro and playing with your own swing both on the course and at the range is how you're going to learn some of those things. But trying not to overswing and understanding what your body mechanics will allow you to do. That yin and the yang, the rotation and the follow through are the things that are going to make all the difference. But especially as we age, please try to avoid that hyperextension. That old pretty picture on the follow through that we had when we were kids are also the things that are going to lead to more pain in the low back as we try and overswing on the follow through. Using your club as a means to stretch, trying to use either a longer pole, I don't care if it's a broomstick, a hockey stick, whatever it is, but just the idea that you're trying to use that to leverage yourself, to understand where your weight and your mechanics should sit, and then trying to use that to stretch the back and stretch the shoulder blade muscles as well as the thoracic rotation, I think is really a key element towards both our off-season training and even during our season to try and maintain our flexibility and towards injury prevention. Hip, again, hip has become a really popular topic, both for us in sports medicine and in the golf community, because we've talked about it for a while now in terms of our pitchers and something called a GERD, which is a general loss of internal rotation on that lead leg. But that's where we start to see some of the power generation. And that's one of the things that we can't really maintain, because even as we age, we don't necessarily have to lose the power through those gluteal muscles. Whether or not you've had a replacement or not, those are the muscles that are going to help us to keep generating energy. But they're also the thing after contact, which help us to slow the ball down, slow the club down, to avoid trying to end up way over the top on that hyperextension injury. Labral tears, this is just a couple of pictures. I just want people to think in terms of, how we address hip pathology now and what our expectations in the sports medicine community are such that, we really can talk about doing pretty much whatever we need to do from an arthroscopic perspective on the younger athletes. We generally see a pretty big drop off in the number of people that we're operating on with the scope or with the camera as we get over 50. It's not a hard and fast number, but the outcomes from the surgeries, there's a big drop off. And so, I think that most people should understand that no matter what we do, we have a solution to most of the problems around the hip. But, even if it ends up being a hip replacement, which is what you'll see in the bottom right, you should expect that if you have surgery at this point, you will get back to playing. I think that's really the big thing. These are the exercises that I like to talk about with people in terms of those clamshells. We've talked about the bridges. Simple things, and I don't care whether you're big, small, overweight, or not overweight. These are all exercises that you can do. I'm happy to get you a copy of these exercises for you, and certainly you can message us afterwards, and we're happy to go through that. But just these kinds of basic exercises of working the muscles that both bring the hip in, bring the hip out, rotating the hip out, and rotating the hip in. And so the hip is a pretty constrained joint in that it's really, really tight inside there, but it's also what allows us to bring the out and in and the rotation, which is the things that we should be able to maintain and maintain our muscle mass as we age regardless. Knee, thankfully, it's an interesting thing. Most of the people who ultimately end up with maybe replacement in the older population is not a result of golf injury. Golf injuries tend to be broken down, again, into the overuse versus the mechanical injury. Meniscal issues, shock absorbers, things that we can maybe do a scope. But for the most part, what we're looking at when we talk about knee things is just trying to understand that swing mechanics, that natural ebb and flow as we roll through from our hips to our knees. But again, the days where we're used to really bend at our knee are gone, and there's a lot more of the tight coiling and less of that separation through the knee and the rotation to try and prevent the injury. Meniscus tear is a kind of shock absorber. The articular cartilage or the cartilage injuries are usually the cartilage that lines the bone, which is the white shiny stuff on the end of a chicken bone. When your cartilage breaks down, that's really what arthritis is. When they're smaller issues, when they're mechanical issues, those are the things that we'll talk about, arthroscopically fixing those. But for the vast majority of things, we're talking about anti-inflammatory stretching, strengthening, possibly a cortisone injection, possibly something called a visco supplement, which is a gel injection. But I just want everybody to understand that, whether or not you end up needing a knee replacement or not, and I certainly am not advocating anybody for that, you should expect with great certainty that you should be able to get back to playing golf, whether you're having a hip replacement, a shoulder replacement, or a knee replacement. We know that golf, for the most part, is played by a more mature population. Arthritis is more prevalent in that population. And so, shoulder, hip, and knee replacement, I'm sure anybody who's playing, let's say, regular golf over 50 at this point probably knows at least one person who's had one of those joints replaced. I always like to tell my folks, as long as you got a problem we can fix, we're doing okay. It's when the doctor says, boy, you're interesting, maybe that's the time that we're a little bit more concerned. But The overall return to play or return to golf, an increased number of rounds is over 90%. So if you end up with a knee replacement or a hip replacement at this point, we expect not only are you going to get back, but statistically you're going to get back playing more rounds than you did in the past. Unfortunately, though, when we look at this, we did not see much of a handicap change. So I don't want people to think that they're getting a joint replacement because they're going to go from the teens down to single digits. But I do think you should expect that you should be back playing with a reasonable amount of certainty, pretty well pain-free, even if you don't see a big drop in your handicap. We know that people who have had joint replacement, and I think this is why it's important that you know that these are the problems that we can fix, is that we will see a total increase in rounds per year. The average return to play from hip or knee replacement, and doesn't mean normal, but just getting back out there, is about 2-ish months. Patients reported an increase in driving distance after knee replacement, but when we really looked at the statistics, it probably was pretty marginal. There's definitely a preponderance of men over women getting joint replacement within the golf community. But you should feel like there's no limitation on you going back to golf, whether you have your hip or your knee replaced. Again, sorry, it doesn't change your handicap, but I think if you can go out and play more, you're going to be better off in the long run. So in summary, I think that, we talk about most of these things as overuse, which is why we use the off season to try and really breed good strength and stability exercises. Try and think in terms of good conditioning in off season, so you're ready when the weather breaks, so that your body can withstand the repetitive forces of swinging the clubs or going out and hitting ball after ball on the range. I think the focus really needs to be both on your hip flexibility and your thoracic or your trunk rotation, but maintaining your shoulder blade muscles in the off season is going to be the thing that really helps to keep those things balanced and keep that swing and follow through phase really balanced as you move through the rest of your season. So with that, I'll say thank you. I hope we have some questions. If it's a chronic problem, it's whatever feels better. There's no right or wrong. I can find you literature to support both things. If it's, I just got hurt, I just had an injury, I twisted my ankle, ice. It has a nice numbing effect. It helps to reduce the swelling, keeps the joint mobility. Having said that, though, in the things where we're seeing more chronically problems, you may have to play with it a little bit. There's no right or wrong to that. It's whichever feels better for you. Okay, I'm going to go a little bit non-traditional on this. I think if you look at the data around the physical therapists who are doing some of these things, one would be what's called myofascial release, which is that kind of deep cross-friction stretching things to try and break some of the adhesions down. Will help to try and increase the mobility, but it does not change the blood supply. If you want to look at some of the less traditional things, red light, laser, near infrared, wavelength type therapy. I think there's some data which would say that that's maybe helpful in the more superficial joints like the elbow, because what we do see is in certain activities that will increase blood flow to the area. It certainly creates a little bit of vasodilation, and a little bit what's called nitric oxide release, which helps to get more vasodilation. But in terms of like as a massage technique to get more blood flow, it's not really going to do it. When you're talking about exercising for a golfer's elbow or a tennis elbow, for the most part, you're trying to create muscles around that area to kind of build those up to support that one little small area that may not be as strong as you'd like it to be. I'm a fan of cross training. So yes, I like swimming. I think especially for people who have arthritis, I think it's a really good total body exercise. I think it's nice because of the buoyancy, and it really creates length, which you generally don't get amongst the runners and the rower and the ellipticals. I think the most important thing that you need to think back is my mantra of good health, which is you need to balance flexibility and balance with resistance training, with endurance training. The idea that we're going to get on an elliptical for 45 minutes, 5 times a week, and it's going to really have a phenomenal strength benefit, it ain't going to do it. American Heart would say we want 30 minutes. We'd like to see you doing it 5 times a week for endurance training, just to get our heart rate up. But as a means of maintaining muscle mass, as a means of trying to really maintain flexibility, getting on those machines in isolation and just doing that by themselves is not going to do it for you. You really need to work on both strength with flexibility and balance with endurance.